Okay, let us continue. I am back. If you can hear me, indicate. All right, so yes, we ended the first session with a discussion in terms of accessibility to EMS response. And yes, it is definitely an issue in Jamaica. So there's a portion of the population that will not have access to ambulance with trained personnel on that unit. And time will tell if the government addresses that. It's not something I expect the government to address, because the percentage of the population that is affected by it, by not having access to proper EMS response, doesn't have the public health knowledge to know that it is something they are entitled to. So until that knowledge gap is breached, they are going to continue to put people in vehicles. Right, now let's continue with the patient assessment chapter. We're on circulation. We're talking about the methods for controlling bleeding. Right, now after you have controlled bleeding, the next phase, once you have completed your circulation assessment, the next phase is to determine whether or not you need to do a rapid scan or you need to do a focus assessment on your patient. So perform a rapid scan. The scan the body to identify injuries that must be managed or protected before the patient is transported. It should take 60 to 90 seconds to perform, not a systematic or focused physical examination. And you will be using your DCAP BTLS, right? DCAP BTLS. Later down in the PowerPoint, you'll come across that acronym. Not going to go into it now, but you're using a DCAP BTLS at this point. So the rapid scan can be a rapid head to toe, or based on the patient's presentation, you can focus on the point of injury. So this is how it works. If it's a trauma patient, so if you have a trauma patient, what determines if you do a rapid scan is the mechanism of injury. So if you have a trauma patient, regardless of whether or not this patient is responsive or unresponsive, you will consider the mechanism of injury. Once your mechanism of injury is diffuse or significant, then you must perform a rapid head to toe on that patient. You must take C-spine precautions. You must use a spine board to move this patient, right? So it's the mechanism of injury for trauma patients. For your medical patient, what determines if you do a rapid scan is whether or not that medical patient can tell you exactly what their chief complaint is. So if you're not able to get credible information from your medical patient about what the chief complaint is, then a rapid head to toe is necessary on this patient. And you're not only looking at trauma for medical patients, you look at trauma for trauma, and you'll also be looking for clues to medical issues, right? So you'll be looking at whether the pupils are reactive on both sides. You're looking for symmetry. Does the right side of the face match the left? How does the patient's skin feel? Is there signs of an infection? Are there abnormal rashes, signs of abscess? So you're looking for medical clues as well as trauma for a medical patient. So again, to determine if a rapid scan is needed for a trauma patient, you look at the mechanism of injury. If the mechanism of injury is diffuse or significant, a rapid scan. If the mechanism of injury is localized, then all you have to do is focus on the point of injury. The medical patient, if the patient can tell you clearly what the chief complaint is, you focus on the system involved. If they are not able to tell you, then you perform a rapid scan for the medical patient. So after you have completed your rapid scan, next is, what is the priority of your patient? Is this a load and go patient? Is it a stay and play? Determine the priority of your patient, care, and transport. Primary assessment assists in determining transport priority. High priority. Any patient in which the ABCs are compromised and you are not able to stabilize it in the field will require rapid transport. So high priority, uncontrolled bleeding, responsive, unable to follow commands. For general impression, difficulty breathing, definitely unresponsive. Severe chest pain, pale skin, or other signs of poor perfusion, complicated childbirth, severe pain in any area of the body. These are high priority patients. Now, you have something that is referred to as a golden hour. Well, it used to be called the golden hour, it's now the golden period. Right? So the golden hour or the golden period is the time from injury to definitive care. So this is the 1 hour in theory or in concept. So this 1 hour entails somebody contacting dispatch and EMS dispatch. The dispatcher gets the information, decides if BLS, ALS, police, fire, whatever response is needed. Dispatch these responders to the scene. The EMS responders assess, manage, and package the patient, and then transport that patient to the most appropriate facility. All of this must take place within an hour. So that's a golden hour, right? And within that golden hour, there is the platinum 10, and that is where the platinum 10 focus on you as the responder as it relates to the patient. So it should take you no more than 10 minutes to assess your patient, provide treatment, and get your patient packaged for transportation. That's 10 minutes. And you have, within that 10 minutes, you have 6 minutes to assess the complete your primary assessment and manage life threats. Now, definitely, you will encounter situations that take you outside of the golden period or hour because a patient might be trapped. The patient might be trapped in a vehicle and you have to wait on fire to come and create access. You can get that patient out of the vehicle. Right? It can also be a situation where you're waiting on medevac for that patient. So there are circumstances in which you may end up outside of the golden hour, and that's why they have changed it to golden period. So the patient needs to get pre-hospital care and definitive care as soon as possible. Right? That's what we call the golden period. Certainly you don't want to be going outside of an hour, maybe 2, right? And within that golden period, you have a platinum 10 minutes, where you have to assess, manage issues, package, and transport, and get your patient ready for transport. Now, transport decisions should be made at this point based on the patient's condition, the availability of advanced care, distance of transport, sorry, and local protocols. And that would be the end of your primary assessment. Yes, Miss Lewis.
Sorry, sir, that one is on error.
Okay. So that would be the end of your primary assessment. Right? So your primary assessment consists of your general impression of the patient and the environment that you find the patient in. You will assess the patient's level of consciousness. You assess the patient's upper airway. You will assess the patient's lower airway. You will assess circulation. Based on those findings, you will determine if your patient requires a rapid scan or a focus. Then, what is the priority of your patient? Is it a load and go patient or a stay and play? We want to get all of this done within the golden period or hour. Next would be history taking. So this is where you're going to ask questions based on the chief complaint. Right? And you should include the demographics of your patient, date of the incident, patient's age, gender, race, past medical history, and current health status. So you're going to get information directly from the patient, or you get information from bystanders or family members. So investigate the chief complaint, make introductions, make the patient feel comfortable, and obtain permission to treat. Ask few simple and direct questions. Refer to the patient as Mr., Miss, or Mrs. using the patient's last name. Use open-ended questions unless there are circumstances that exist in which that would not be appropriate. You want them to be detailed and discuss things, but that may not be appropriate in all cases. So if a patient is having significant difficulty breathing, then you might want to ask yes and no questions or close-ended questions. If the patient is unresponsive, patient information and clues about the incident may be in from family members present, a person who may have witnessed the situation. Bystanders, look for your medical alert jewelry. You'll see that more overseas. And I've seen medical jewelry here as well. Other patient medical history documentation must be. So you need to consider other information as it relates to the medical history of the patient and if it is relevant to their current presentation. You will use your OPQRST mnemonic, right? So you're gonna use your OPQRST mnemonic, and this mnemonic, all of the letters OPQRST, you will ask all of these letters if your patient is complaining of pain. Right? So if the patient complains of pain, OPQRST will be asked. For other conditions, you might not ask all of the letters, just what is appropriate. So the onset is when the pain started. That's onset. When did the pain start? Right? Provocation or palliation is, can you tell me what makes the pain better or worse? Quality, how would you describe this pain that you're having? Don't put words in the patient mouth. Let them tell you. Region, where is it exactly that you're having the pain? And that pain that you're having, do you feel it move to anywhere else on the body or in the body? That's radiation. Severity, on a scale of 0 to 10, 0 being no pain, 10 being the worst, what number? Or you can say on a scale of 1 to 10, one being the lower end, 10 being the high end, what number would you give the pain? And if they say the pain is, they said that the pain is 9, was it 9 from the onset? They need to find out what the severity was from the onset to determine if it's getting worse or is it getting better. So the timing is the pain constant? Does it come and go? Right? So is it consistent pain? Does it start? Does it stop? Or is it there? It's just there. Right? And you can think about your pertinent negatives. Now, pertinent negatives would be findings that you would expect the patient to complain of, but it's not there. Right? So, for instance, a patient does an ECG and shows signs of a myocardial infarction, but the patient is not having any chest pain. All the patient is complaining of is being lightheaded. So chest pain being absent would be a pertinent negative. So apart from the OPQRST, which is tend to be more specific to pain, it's very specific to pain, but you can use it for other conditions. There are certain aspects of the OPQRST that you can ask other medical problems. You will obtain a sample history, and it's really ample history that you would be doing at this point, because when you get to this stage of history taking, you should already know what your signs and symptoms are. You should already know that, right? So the signs is what the patient tell you. The sign is what you see, hear, smell, and what can be measured. The symptoms is what the patient tell you. So you should know what that is at this stage. Ask the patient, are you allergic to anything, any food, medication, allergies? Ask that question. Medications, are you on any medications? If the patient say, yes, I'm on medications, okay, which medications you're on? Why are you taking this medication? What's the purpose of the medication? Pertinent past medical history. Do you have any history of medical conditions for which you were diagnosed by a doctor? Last oral intake, that's the L. What was the last thing you had to eat? What exactly did you have to eat? When did you have it? Events. Events leading up is similar to onset. What exactly were you doing prior to having the difficulty breathing or chest pain? What exactly happened before you lost control of the vehicle? That's events. All right, now your critical thinking in assessment. You're gonna be gathering and seeking facts. You have to evaluate these facts. So consider what the information means to you, and then synthesizing, putting the information together. So based on all the information you have gathered, what is the best approach to manage the situation? Now, taking history on sensitive topics. So you can have patients that are taking alcohol or drugs. Signs may be confusing, hidden, or disguised. The patient may deny having any problems. History gathered might not be reliable information. Do not judge the patient, be professional in your approach, and it's never more than 2 beers. No matter how drunk the patient is. Just 2 beers I had, 2 beers. Then you have the physical abuse or violence. Report all physical abuse or domestic violence to the appropriate authorities. Follow local protocol. Do not accuse. Instead, immediately involve law enforcement. So in the States, once there is the patient say, yes, I was abused, you have to get law enforcement involved. Sexual history. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant. Inquire about urinary symptoms with male patients. When appropriate, ask all patients about the potential for sexually transmitted diseases. Then you can have the silent patient. Patience is extremely important. Now, the fact that the patient is silent, make sure you don't breach what I would consider to be striking distance, right? So you want to maintain arm's length or 2 times your arm's length from these patients. But you don't know what the patient is capable of doing. So patience is extremely important. Use closed-ended questions that requires a simple yes or no answer. Consider whether the silence is a clue to the patient's chief complaint. And you may not be able to find out anything about this patient. Matter of fact, you may not even get the chance to treat the patient. Because I've had situations where the patient not saying anything, and for this particular call, the patient was in the neighborhood walking up and down naked, and then he went up to his apartment, and police came. The police were there before we got there. And when the police went up, the police went inside, and I stood at the door. I ain't going inside there, right? Because it was a small space, very small, so I have no room to maneuver. So I stood at the door, and I had my medication in my pocket in case the police officers jump on him, that I could sedate the guy. And he was naked. His girlfriend was in front of him, and the girlfriend had talked to him. And I said, "What's up? What's happening? What do? What's going on?" And he's not saying a word. He didn't say anything at all. And the officer, there was an officer behind him and an officer in front of him. And the officer in front gave him instructions. He should turn around and face the wall and put his hands behind his back. And I mean, he said it to him probably 1 or 2 times. He didn't respond. And the police officer said to him, "Is either you do it willfully or forcefully. Is either you're gonna do it on your own or I'm gonna make you do it." And when the officer said that to him, he turned around, walked towards the wall, and put his hands behind his back. He did not say a word, right? Nothing at all. And the officer said to me, give us a couple minutes. And we went down and we were in the ambulance. And then they came down and said to us that we can leave. They will leave this call. And I just left. I didn't question it any further, right? So you might not be able to get any information at all from the patient. But remember, don't reach that distance where you can be grabbed, or you're going to be at a disadvantage if the patient should try to hit you. Then you have the overly talkative, right? Reasons why a patient may be overly talkative is caffeine consumption, and that would cause the blood pressure to go up. It's similar in its effects to epinephrine. Nervousness, ingestion of cocaine, crack, or methamphetamine, all of those, cocaine, crack, meth, these are stimulants. So they are similar in effect to adrenaline. They're going to stimulate, they're going to increase stuff inside of the body. Underlying psychological issues may be a factor as well. Then you have the patient with multiple symptoms, and this is going to be common in a geriatric population. So you're gonna have to cipher through the information that they're feeding you. What is important that I'm getting now that is affecting the current presentation? You're gonna have to be patient with these patients, right? So often true of older patients, characterize the patient's complaint as you would in triage. Start with the most serious, end with the least serious. Then you have that patient that is anxious, anxiety. Some anxious patients show signs of psychological shock. So they have physiologic changes that is associated with the anxiety. Feel sweaty, that's diaphoresis, shortness of breath, numbness in the hands and feet, and you'll see numbness in the hands and feet or spasms in the hands and feet if they're hyperventilating. Dizziness or lightheadedness, loss of consciousness. Then you have the angry and the hostile patient. Friends, family, or bystanders may direct their anger and rage toward you. Can be from the patient specifically. Remain calm, reassure the patient the family members as much as possible. Be gentle in your conduct. If the scene is not safe or secured, get it secured. Right? So if you don't feel safe, you probably need to back out. Right. Now, intoxication. So the intoxicated patient. Do not put an intoxicated patient in a position where he or she feels threatened. The potential for violence and physical confrontation is very high. Alcohol dulls the patient's senses. And again, maintain that preferred distance and communicate. And once your striking distance is breached, so once a patient or somebody that seems to be getting aggressive towards you, breach your striking distance, which is your arm's length. So once somebody is within your arm's length, you can be hit. Once that breach occurs, you need to cut your angle, right? So when I was working as a correctional officer, when I was dealing with inmates that seemed like they want to get aggressive and breach my striking distance, once my striking distance is breached, my arms do not go below my waist. So you see that I'm gonna have my hands up in a passive way, or I'll have my hands at my chin with the other hand supporting the elbow. So my hands are not gonna go below my waist, because if the person is within my striking distance and my hands are below my waist, I can't stop a strike with my hands below my waist. And the other thing I will do is I'll cut the angle. So if they start to get aggressive and they breach my striking distance, then I cut the angle. What does that mean? I change my position so that they have to follow me, right? So I don't square up with them. I change my position so that they have to follow me. So if they are following me and they attempt to strike, I will see that strike coming. I am able to counter it much faster because they have to change their position to line up with me in order to hit me. And if they are not lined up properly, they can't hit me. They will have to position. So if you're following me, I am already in position. So I have the advantage. So you will never ever put yourself in a position that you're at a disadvantage. Don't allow crowd to form a circle around you, and don't allow aggressive persons to breach your striking distance. If it's breached, keep your hands above your waist. You can be passive, or as I say, you can put one hand on the side of the face, use the other hand to support the elbow. I prefer the passive approach because both hands would be up, right? And I am going to be very passive, very passive. I don't get aggressive if somebody is aggressive with me. I am very passive. Hey, I'm just trying to do my work. Calm down, take it easy, doing our best, but my hands are up and ready to go at that point. Now, you can have the crying patient. Patient who cries may be sad, in pain, or emotionally overwhelmed. Remain calm, be patient, reassuring, and confident, and maintain a soft voice. Then you have the depressed patient. Among the leading causes of disability worldwide, symptoms include sadness, hopelessness, restlessness. They get very irritable. They have sleeping and eating issues. They have less energy. They have a decreased level of energy. Be a good listener. Oops. Okay. Then you have the confusing behavior or history. Conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drugs could alter patients' explanation of events. And older patients can have dementia, delirium, or Alzheimer's disease. Not going into these conditions now, we could talk about them much later on in the course. Then you have the limited cognitive abilities. Patients with limited cognitive abilities. Keep your questions simple, but kill the patient with medical terms. So don't overwhelm them with medical terms. They're not going to understand anything what you say. Be alert for partial answers and keep asking questions. Rely on the presence of family, caregivers, and friends to supply answers. Patients with cultural challenges. Do not use medical language. Patients may prefer to speak with healthcare providers of the same gender. Gain the assistance of patients' friend or family members. Enlist help of healthcare providers of the same culture or background, if that is possible. Then you can have your patients with communication issues or language barriers. Find an interpreter if possible. If possible, right? One of the good things about the partner that I had when I was in Texas is he spoke Spanish. And the area that I was at in Texas, Fort Worth, a lot of the calls were from Latinos. So that was a plus. But that might not always be the case, because I remember there was a particular call that I didn't work with him, and the patient and the husband don't speak English, and she was not in good shape. She was not in good shape at all. Young female, close to full term pregnancy, found unconscious with her tongue swelling. And when I arrived at the location, she was on the ground. She had on no panty, and she's not responding. And the husband don't speak English, could get an interpreter. Right? That was not a goal for me at all. Okay, it's gonna happen. So it's not in all circumstances you're going to have an interpreter available. So keep questions straightforward and brief. Use hand gestures. Be aware of the language diversity in your community. You can have patients with hearing problems. Ask questions slowly and clearly. Use a stethoscope to function as a hearing aid. So you would put the earpiece of the stethoscope in the patient's ears and then speak through the diaphragm. Learn simple sign language to help with communication. Use a pencil and paper. You have patients with visual issues. Identify yourself verbally when you enter the scene Then these patients normally have their home set up a particular way. So if you move something, you have to ensure that you put it back, right? So you have to put back whatever was moved in the position it was before. That's how they move around. And some of them have guide dogs. You may have to transport the dog with the patient. Explain to the patient what is happening in each step of the vital signs assessment. And that would be your history taking. Now, the next phase, so we have looked at scene size up, we have looked at primary assessment, we have looked at history taking, which focus on the chief complaint. We will be using the OPQRST and the sample history, or ample history. And of course, we have to consider the various types of patients that can have communication challenges as it relates to us as EMS providers. Then the next phase is your secondary assessment. So it may be performed at the scene. Rarely that is going to happen, right? So a secondary assessment will rarely occur at the scene, right? Can happen in the back of a unit, but the nature of most emergencies will rarely give you the chance to perform a secondary assessment. You can move a component of your secondary assessment into your primary. So you can move a focus assessment into your primary and perform that instead of a rapid scan. But to do a detailed head to toe, that's not going to happen in most emergencies. So a secondary assessment may be performed on scene in the back of the ambulance or en route to the hospital or not at all. The purpose is to perform a systematic physical examination of the patient. So it's a detailed, systematic head to toe or focus assessment. And in this stage, you will also do what we consider to be recorded vital signs. So the main purpose of the secondary assessment is to pick up findings or to look for things that may have been overlooked because you were focused on life threats, or to look for things that develop slowly. That's the main purpose. To look for things that may have been overlooked because you're focused on life threats or conditions that will become more critical over time or develop slowly. So how and what to assess? We will inspect. So we use inspection. We look at the patient for abnormalities. We use palpation. We touch or feel the patient for abnormalities, and we use auscultation. Listen to sounds as the body sounds the body make using a stethoscope, and specifically lung sounds. So that's the best way to listen to lung sounds, using a stethoscope. You will use the mnemonic DCAP BTLS, and this is the same mnemonic you will use in your rapid scan. DCAP BTLS. D is for deformity, A is for contusion, A is abrasion, P is puncture, penetration, and paradoxical motion. B is burns. T, tenderness, L, laceration, S, swelling. You will also look for or discover instability, that's I, and crepitation, which is another C. That's when broken bones are rubbing together under the skin. So you compare findings on one side of the body to the other side. So you're going to be doing bilateral evaluation. So systematically assess the patient, right? The goal is to identify hidden injuries or identify causes missed during the 60 to 90-second exam during your primary assessment. I've said this previously. The focus assessment. So it can be a focus assessment, it can be a detailed head to toe. Performed on patients who have sustained non-significant MOIs or unresponsive medical patient. And this can be done in your primary assessment. So you can do a focus assessment in your primary. If the mechanism is localized, where the medical patient can tell you exactly what's happening. Typically based on the chief complaint. Goal is to focus your attention on the body part or systems affected by the priority problems. So let's look at the respiratory system. How do we systematically assess the respiratory system? You expose the chest, you look for signs of airway obstruction, inspect for symmetry. Does the right side of the chest look like the left side of the chest? You listen for breath sounds. Apex, left and right, base, left and right, that's mid-axillary, and the same at the back. Apex, mid, and can go base. So you can go 6 points at the back, 4 at the anterior. And depending on what your protocol allows, you can go more than the 4 at the front, right? Once your medical director approves of it. But generally, it is apex, anterior, base, mid-axillary, 4 points at the back or 6 points at the back at the EMT level. I'm not expecting anything outside of that. So listen to breath sounds, measure the respiratory rate, look for retractions, and increase work of breathing. Respiratory rate, a normal respiratory rate for an adult is 12 to 20 breaths per minute. For children, they're gonna breathe much faster. When you're evaluating the patient's breathing rate, you will look at the patient's chest rise, count the rise and fall of the chest as 1. So count the rise and fall as 1. You count that for 30 seconds, multiply it by 2. Do not use 5 seconds, do not use 15. Because there are some patients that can have pauses as long as 5 seconds or more. So 30 seconds, multiply by 2. If it's irregular, do it for a full minute. If the patient cannot be talking to you when you're checking the breathing rate, and do not tell the patient that you're going to be checking your breathing rate. Just when I am doing my checks, all I said to the patient is, or sir, I'm going to be doing some checks on you. If there's anything that I see requires treatment, treatment will be provided, and we will explain the treatment process. And then you do your checks. Now, for practice purposes, you can put your fingers on the radial pulse as a distraction and put the hand across the chest for practice, right? To feel the chest rise and fall. In the initial stage of your training, I don't have any issue with that. As you get more comfortable, you need to be able to observe the rise and fall without putting that hand across the chest. So I don't have any problem putting the hand across the chest, especially if your patient is not responsive or unresponsive. But if it's a responsive patient, they might pick up that you're checking the breathing, right? But I always grab the radial pulse as a distraction. I'm not checking the radial pulse. I'm using it as a distraction and observe the ventilation pattern. Now, with the respiratory system, you're looking at rate, rhythm, quality, and depth. We know this. The regular, with the rhythm, regular. The time from one peak chest to the time from one peak chest rise to the next is fairly consistent. Irregular, the respirations vary or the rate changes frequently. We know this. Quality of breathing, is it normal breathing? Normal breathing is silent. Breathing accompanied by other sounds may indicate significant respiratory problems. So is there abnormal sounds? Is it positional? Is there work of breathing present? Or labored breathing? Depth, the amount of air the patient exchange depends on the rate and tidal volume. So what is the rate that the patient is breathing at, and can you see adequate chest and fall bilaterally? Breath sounds, you can almost always hear breath sounds better from a patient's back, and you must make skin contact with the diaphragm of your stethoscope. All right, now what are you listening for? Normal breath sounds, snoring the tongue, wheezing, obstruction in the lower airway, crackles is fluid in the lungs. Bronchi is also fluid, but it's thick, that's pus in the lungs. Stridor, upper airway issues. No, so that's the respiratory. Cardiovascular, look for trauma to the chest, listen for breath sounds, consider pulse, respiratory rate, and blood pressure. Pay attention to rate, quality, and rhythm for the pulse. So if you assess respiratory, you will assess cardiovascular. Consider your findings when assessing the skin. Check and compare distal pulses, bilateral. Consider auscultation for abnormal heart sounds. Right. Normal pulse rate for an adult, 60 to 100 beats per minute. The younger the patient, the faster your heart tends to beat. And there's a nice little table for that. Don't get too caught up on numbers. Remember that primary one, 60 to 100. Younger they are, faster the heartbeat. If there is an abnormality present, is there associated symptoms? Pulse quality, describe as stronger than normal pulse as bounding. So describe as stronger than normal pulse as bounding. A pulse that is weak and difficult to feel is described as weak and thready. Pulse rhythm, regular. The interval between each contraction should be the same. The pulse should occur at a constant, regular rhythm. Irregular, if the heart periodically has an early or late beat, if the pulse beat is missed. And once you have a patient in which their pulse rate feels irregular, it means the patient has an issue with their heart. Something is wrong with their heart. Blood pressure. Pressure of circulating blood against the walls of the arteries. A drop in blood pressure may indicate a loss of blood or fluid components, a loss of vascular tone, and sufficient arterial constriction. So it's either too much blood loss or something is causing the blood vessel to dilate too much, or something is directly wrong with the pump, which is the heart. Right? So when the blood pressure will be affected by loss of the blood or fluid components, vasodilation of the blood vessels, or something wrong with the heart muscle itself. Decreased blood pressure is a late sign of shock. So once the blood pressure is low, the patient is now in what we would classify as the decompensating phase of shock. Abnormally high blood pressure may result in a rupture or other critical damage in the arterial system. A blood pressure cuff, the gauge contains the following components. We're not going to go through this section because that's practical. Right? So this is practical, being able to obtain a blood pressure reading. We're going to go through this in practice. Normal blood pressure. Hypertension, blood pressure that is lower than normal. Hypertension, blood pressure that is higher than normal. Right, now the neurologic system should be performed with any patient who has changes in mental status, possible head injury, stupor, dizziness, drowsiness, syncope, or fainting. Neurologic assessment, you will evaluate the patient's level of consciousness using the AVPU scale. At this stage, you will definitely be doing a Glasgow Coma scale, which looks at eye opening, verbal response, and motor response. And the patient will get a value for each. So there's a value for each section. The most the patient can get is 15. Ensure that you look at it in your book. I don't think I have a slide with GCS on it. Go through it. It's looking at 3 areas: eye opening, verbal response, and motor response. For the pupils, the pupil is the black center portion of the eye. The pupils are normally round and of approximately equal size. In the absence of light, the pupils will become fully relaxed and dilated. So once light shines in the pupils, they constrict. When you move away the light, the pupils relax and dilate. Now, these are the reactions that can occur that you might need to be concerned about. So at the top here, if you shine the light in the pupils and they look pinpoint like this is what we call pinpoint pupils. This would be a patient that has overdosed on a narcotic analgesic agent. So this might be a heroin overdose. It might be the patient overdose on fentanyl, alfentanil, oxycodone, oxycontin. Once it's a narcotic analgesic, it causes the pupils to constrict and it shuts down the brain, and that can shut down the patient's ability to breathe. Now, down here, if you shine a light in the pupils and it looks like this, where they're dilated with the light source, it means that there is pressure. There's some pressure building up inside of the brain. So this is a patient, a possible head injury patient, right? Dilated pupils might be a possible head injury patient, or it can be the patient dead, right? On this side, if you shine a light and one pupil look like this and the other one looks this way, where it's fully dilated, this can also be an indication of a head injury, right? It can also be that the patient was born that way. So the patient could be born with unequal pupils. It's called anisocoria. But until you have evidence to support that it is anisocoria, think about head injury. So a small number of the population exhibit unequal pupils and anisocoria. Causes for pupil abnormality is going to be linked to depressed brain function, injury of the brain or brainstem, trauma or stroke, brain tumor, inadequate oxygenation or perfusion, drugs or toxins. We describe the pupils using the PEARL acronym, PEARRL. Right, so pupils equal and round, regular in size, react to light. So quite a few acronyms that you need to be familiar with. Now for the neurovascular status, check for bilateral muscle strength and weakness. Complete thorough sensory assessment. Test for pain, sensation, and position. So if you suspect spinal injury, or you suspect a head injury, or you suspect an injury to a limb, you will incorporate pulse, motor function, and sensory function. That's your neurovascular assessment. The pulse check in this assessment is not the same pulse check in your circulation. So when you're doing a pulse check in your neurovascular assessment, all you're checking is to determine if there is circulation still going to the limb. You just want to check to see if circulation is there. You're not interested at this point in finding out what is the rate. Is it strong? Is it, you just want to know, is there circulation still flowing to that limb? That's a neurovascular pulse check. So apart from that pulse check, you're gonna check to see if there is still sensory nerves in the area. So can the patient feel when you're touching them? Can they, that's the sensory component. And you will evaluate whether the motor nerves are working as well. So can the patient squeeze your finger? Can the patient push on your hand with their foot, right? So you check pulse, motor, and sensory nerve. Now for the anatomic regions, head, neck, and cervical spine, you palpate the scalp and skull, check the patient's eyes, check the color of the sclera, that's the white part. Assess the patient's cheekbones, check the patient's ears, nose for fluid. Check the check the upper jaw and the lower jaw, that's the maxilla and mandible. Open the patient's mouth, look for any broken or missing teeth. Note any unusual odors that's coming from the mouth. For the chest, inspect, visualize, and palpate. Watch for both sides of the chest to rise and fall together with normal breathing. Observe for abnormal breathing signs. For the abdomen, you will palpate quadrant by quadrant. So you palpate for tenderness, rigidity, and guarding. For the pelvis, you inspect for symmetry. So you're gonna hold both sides of the pelvis. You push in and down, not too forcefully. Push in and down. So inspect for symmetry and any obvious signs of injury, bleeding, and deformity. Once you are palpating the pelvis and you detect that something is wrong, deformity, possible fracture, do not release the pelvis until it is stabilized. So it needs to be stabilized before you move on. That can kill a patient. Extremities, inspect for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate for deformities. Check for pulse, motor, and sensory functions. The same checks that you did from head to toe, anterior, you need to do them checks, posterior. So inspect the back for decap, BTLS, symmetry, and open wounds. Palpate the spine from the neck down to the pelvis. So you're looking for step deformity. You're gonna run your fingers down the spinal cord to see if there's any deformity or tenderness in the area. Right? Now, apart from doing your systematic assessment or detailed systematic head to toe in your secondary assessment, you have to do a set of recorded vitals. And you may be required to use some monitoring devices. To use appropriate monitoring devices should never replace your comprehensive assessment of the patient. In other words, don't treat the equipment. So even if you're using monitoring devices, don't treat your equipment, you treat the patient. So pulse oximetry is used to evaluate oxygenation's effectiveness. Pulse oximetry measures the oxygen saturation of the hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. So a patient might have a good pulse ox reading, but their oxygenation level inside of the body is not good. So you have to look at the patient presentation. What is the patient presentation? Tell you what is the pulse ox saying. So the patient may require oxygen with a good pulse ox reading, or you may have a patient with a poor pulse ox reading, and it doesn't matter how much oxygen you give the patient, the pulse ox don't move. Now, if your service allows, Then you can do capnography as well, and capnography measures the amount of CO2 that the patient is breathing out, and it's a good tool for measuring the effectiveness of ventilation. Very good tool for measuring if your patient is ventilating properly. Can also tell you about circulation and metabolism as it relates to the pH. But you might not see that very much in Jamaica. It's a very prominent tool in the States or overseas or in first world system. So blood glucometry measures the level of glucose in the bloodstream. And then of course you have your non-invasive blood pressure cuff, and most services will carry a digital BP cuff now, or you can just use your cardiac monitor and attach the BP cuff to it and put it on the patient and press a button. Now, even though I worked with the digital equipment, if I get a number that don't seem right to me, I will do a manual BP check, especially if it's low or high. I want to know what it is manually, because the digital devices can give incorrect readings. And that's your secondary assessment. Now, the final phase of the patient assessment algorithm is the reassessment phase, and this is the easiest phase. In the reassessment, all you're doing at this point is repeating your primary assessment. You're going to repeat your primary. You're going to be documenting important information. You're going to be relaying that information to the receiving facility. So perform at regular intervals during the assessment process. You're going to repeat your primary assessment, and in that repeat, you're going to be looking for things that may be getting better or worse. Is your treatment working? Do you need to make adjustments? You will repeat your vital signs. You're going to be looking for trends. So if you have more than one set of vitals, you can see if the patient is going up or the patient is going down. You're looking for trends. So you reassess the chief complaint. You ask and answer the following question. Is the current treatment improving the patient's condition? Has an already identified problem gotten better? Has an already identified problem gotten worse? What is the nature of any newly identified problems? Recheck your intervention. So check all intervention. Most importantly, are the patient's ABCs okay at this point? Ensure that management of bleeding is appropriate. Ensure adequacy of other intervention and consider the need for new interventions. Identify and treat changes in the patient's condition. Document any changes, whether positive or negative. Reassess the patient. Unstable patient, every 5 minutes. So once your patient is unstable, reassess every 5 minutes. The patient is stable, you reassess every 15. However, you constantly monitor your patient. And that's your reassessment. Now, important points to note about the reassessment. And not generally the reassessment, but anywhere you are within your assessment, your patient assessment algorithm. Once something changes in your patient's presentation, always go back to your primary assessment. I'm going to repeat that again. So wherever you are in your assessment, is if something changes in the patient's presentation, start back your assessment from the beginning. So if I am in the process of doing a rapid scan on the patient and I get to the lower extremity and the patient is no longer communicating with me, I will stop palpating the extremities and go straight to the patient's head. Sir, can you hear me? No response to verbal, check pain. Right, so I'm going to repeat. I'm going to start over my assessment, and I'm going to come down. By starting from the top and come down, I will be able to pick up what has changed. If you do not do that, you won't pick up what has changed. And if you don't pick up what has changed, you can't manage your patient effectively. You can't manage the patient effectively, the patient suffers. And that's patient assessment in a nutshell. No. Question 1. Which most of you should already know the answer to the questions, because I sent the PowerPoints yesterday. So, Powell, question 1. Quickly, because it's lunchtime. Powell, present or absent? Yes, Johnson, go.
Let's say another case there. B would have been the incorrect one.
All right, that's acceptable. Question 2, down the line. Cameron, question 2. What was that?
D as in dog.
That's correct. George, question 3.
Sir, primary assessment.
Wilson, what was that?
D, sir.
D,
D as in dog.
that's correct. Patrick Wilson, Romain Terrell. Your time gone, Mr. Wilson. Mute your mic. Terrell, answer the question. Number 5. Go ahead.
I would say D, sir.
B,
D as in dog.
that would be incorrect. Purpose of a primary assessment is to manage life threats. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. Isn't that a significant mechanism of injury? If the mechanism of injury is significant, why are you doing a focus? It's a significant MOI. The patient has an altered level of consciousness. It must be a rapid scan for this patient.
Okay.
All right. Manning. Number 6.
Yes, sir. Number 6 would be responsive to painful stimuli, which is C.
C is correct. Miss Wellington. Number 7.
I would say C, sir.
Assessment of an unconscious patient. Patient's breathing begins at C.
Sir?
So no, that would be incorrect. You can't start assessment of an unresponsive patient by checking breathing rate. Check the airway.
Okay.
So manual positioning is needed at that point. Sequence people, sequential approach. Oil.
Yes, sir.
What's the answer?
Favorite this B, sir.
Okay. Mr. Cameron, number 9. Mr. Johnson, number 9. You hear that?
Go again.
Answer question 9.
D.
B as in boy.
No, dog. Dog.
Okay then. Sound like you're not sure and somebody telling you. All right.
Yeah, man. Dog. Dog.
All right. I hear you. George. Michael Wilson. Number 10.
Sir, C. C, please, sir.
Elliot. What was that? Mr. Wilson?
C, sir.
C. Okay. All right. All right. And that's it for patient assessment. It is lunchtime. We will resume at 1 p.m. That's it for now. Yes, Mr. Johnson.
Sir, Chanteloup not get no questions, sir.
Going based on the names that I see in the room, so not my fault.
Don't kill him, sir.
All right. Do you have any questions? So to be continued.